Welcome, everybody. For those that don't know me, I'm Nigel Biswas-Bourne, co-founder of Fraction. Also joined, I think, by most, if not all, of my co-founders today I can see online. For newcomers, for those that are not so familiar with Fraction or actually live beyond Fraction's network, just to let you know, we are a rapidly growing trusted community of BioPharma functional area experts who can connect together and deliver projects or solve any problems that may be faced by the biopharma community and client community. So that's really Fraction. And welcome to the latest of our webinar, peer-to-peer webinar series. And I think you all heard on your way into the meeting that we are recording. It may be used for marketing purposes. So just wanted to highlight that to everybody today again. Welcome, Doug Neely, our expert speaker and partner at Fraction today. Doug's going to take us through, as you can see, the US market access, a primer for emerging biopharma, EBP, and first launch planning. Now, I saw yesterday, I think, that GSK actually announced their results, and it was the first time the majority of their sales came from ex-US. So really, the rest of the world beyond US was the first time they'd announced their numbers, with the majority being outside the US. So I guess that tells us one of two things. That firstly, it tells us still the importance of the US market, that although not the majority, the large chunk of farmers' income comes from the US market, and clearly it remains very important, but also maybe speaks to the pricing pressures, market access, the evolution of those things in the US market right now. And I think Doug will help us to understand those things a little bit better in his talk. I'll let Doug introduce himself, but just say, getting to know Doug, he's really a US market access leader with primary focus in emerging biopharma and particularly in oncology, which I think many of us online share that passion as well. Doug is a veteran of over 25 years of market access experience, working across both consultancy companies, but also actually within biopharma companies. He's really considered a subject matter expert in the area. So with that, Doug, I hope that's good enough billing, and I'll pass directly over to you. Thank you, Doug.
That is. Thank you very much for that kind introduction, Nigel. And thank you to Fraction for giving me the opportunity to present to this group today. In the next 20 minutes, my goal is to provide a primer to those who would like to get a better understanding of what all is involved when we say US market access, and do that from the perspective of an emerging biopharma company that is in the process also of working on their first launch planning. All right, Nigel, clicking forward, and it's not clicking forward. There we go. As Nigel already provided a summary of my background, I'm not going to repeat all that. I'll only add, or at least emphasize, reiterate that I have led the build out of several pre-commercial emerging biopharma companies. And I say that just to say that I literally have done this work on multiple occasions of building out a market access function while simultaneously preparing for our first product launch. All right, so let's get right to it. Here are my, if you will, core high-level components of US market access. In the short time we have today, I'm going to move fairly quickly, but hopefully provide enough detail to help augment your understanding of US market access and what it looks like from a pre-commercial emerging biopharma perspective. Now, I assume you all have read through the categories here by now, so I'll only add that I will not be addressing the access marketing today, in part because of time constraints, but also because that's typically largely driven by the brand marketing team. But before I jump into the first major component, I want to point out that there are substantial differences from a market access perspective between physician-administered and oral or self-administered drugs. I'll try to point out some of these differences as we move through the presentation, but at a high level, some of the key differences include how products are coded, For example, typically what we call HCPCS codes. They're healthcare common procedure coding system. They're the ones that are used to bill for physician-administered drugs, whereas an 11-digit NDC billing code, aka National Drug Code, are used for billing oral products. There are also differences in payment methodologies, and although not as significant as they used to be, there are differences in plan benefits, so the insurance plan benefit designs that are and needs related to patient and provider support programs between a physician-administered and oral product. Anyways, point made, there are differences between physician-administered and oral products. Now, on to pricing, our first major component. Due to the role pricing can play in portfolio planning and financial projections, I think it makes sense to start with pricing. As some or most of you are aware, there are a plethora of terms and acronyms related to pricing, which are listed in the table on this slide. The most common related to drugs are ASP, average sales price, typically associated with physician-administered drugs, and WAC, or wholesale acquisition cost, typically related to oral products. Now, not listed on this table is a new variation brought forth by the Inflation Reduction Act, and that is MFP, or maximum fair price, which I know we've talked about before. As many of you heard, Medicare has started direct negotiations on a limited number of high volume drugs, and MFP is essentially the reimbursement they are offering for a given drug. For now, this only applies to Medicare beneficiaries and a limited number of drugs, but the number of drugs included will expand in coming years, and we will see if or how commercial payers adopt or modify their reimbursement methodologies. For now, early considerations related to pricing, as listed in the upper right-hand corner, may, for example, include the anticipated indication, the size and average age of the potential patient population, as that will help determine the potential payer mix and the potential impact on payer budgets, and subsequently the need to invest in building a strong value proposition. Now let's move on to pricing's close cousin, which is contracting. I've broken contracting into three main groups: government payers, commercial payers, and GPOs, or group purchasing organizations. This slide depicts a kind of an overview of the government payer landscape. And depending on the anticipated patient population and thus payer mix, emerging biopharma can sometimes struggle with how much effort and resources to put into contracting with all these various entities. For example, if the product is for a younger population, a manufacturer can prioritize commercial payers and perhaps Medicaid. Prioritizing and staggering contracting efforts based on anticipated payer mix typically makes sense, especially for the cash-constrained emerging biopharma manufacturers. I also want to mention the 340B program, which is administered by HRSA, the Health Resources and Services Administration. Under this program, hospitals and health systems that qualify for the program based on certain criteria related to payer mix and or type of location or facility, these manufacturers, for these entities, manufacturers must provide discounts on branded drugs, which currently average around 30%. Now, although the graph at the bottom right, BioQvia, is tiny, you can clearly see the program is growing. In fact, drug volume through the 340B program now exceeds all of Medicaid. So before a manufacturer has even launched their product, they can essentially write off 30%.
Hi. I'm good. Oh, sorry. Let me just finish.
So, can everybody remute their mute their computers? Thank you. Yeah. I was saying that manufacturers can essentially write off 30% of what is a growing and significant number of prescriptions. Note, this is before and separate from any additional discounts or rebates that are negotiated directly with payers. Now we'll move from government payers to commercial payers. As you can see, depicted in this colorful graphic created by our highly insightful friends over at Drug Channels Institute, the large amount of vertical integration that has occurred over the past 10 plus years has resulted in 7 major entities. Each is comprised of an insurance company, a PBM or pharmacy benefit manager, or GPO, group purchasing organization, a specialty pharmacy, and most have some community-based providers, all within that vertical. Now, 7 doesn't sound so bad, but there's more. Unfortunately, negotiating an agreement with a PBM or a GPO doesn't guarantee coverage on down the line. One can think of the discounts or rebates to PBMs and GPOs as just like the ante into a poker game. As depicted in the image in the lower right-hand corner, each of these entities has multiple books of business beneath them, and they may or may not follow the PBM's national formulary. Net, there are multiple layers with which manufacturers have to work with to get appropriate coverage and then monitor them on an ongoing basis. One additional component regarding these vertical entities, by having the insurer, the PBM, the specialty pharmacy, and some providers within the same structure, they have increased their ability to either, force forward a coverage policy or, quite frankly, delay a coverage policy. So they basically gain more control over the utilization restrictions and levers that they're putting in place. But we're not quite done with contracting yet. We still have these broad category of what we call GPOs, group purchasing organizations. And by now, you may be getting a sense of why it costs so much to launch a drug in the United States. As Confucius wrote, life is really simple, but we insist on making it complicated. GPOs are typically broken into along the lines of community-based providers, e.g. physician practices, versus hospital or health systems and other sites of care. Some of the community GPOs are then aligned even further by specialty, with oncology being the most significant or for obvious reasons. By the way, I left the insurer-affiliated GPOs out because they are effectively part of the PBMs in my mind. And yes, there are some other scenarios where manufacturers will also contract direct with health systems or employers or government commercial, or even, but the government commercial and the GPOs are the big 3, is my point from a contracting perspective. So now that I've provided an overview of the contracting landscape, let's take a step back to a core component that significantly improves a manufacturer's position when it comes to the contracting, and that is the value proposition development. I think some of you are probably pretty aware of this one, familiar with this one. This is our next core component, and this is developing a compelling value proposition. As I said, by now I think everyone's aware of the increasing need to demonstrate meaningful value to gain access and coverage. This is one of the core components that needs to be, 1, done in concert with ex-US markets, and B, cannot be started as early, too early. I understand given cash is, basically like oxygen to emerging biopharma. This component, in my opinion, is often not resourced early enough. Even if emerging biopharma intends to out-license or sell their product, a well thought out strategy, preferably with some initial data, will yield a better, licensing deal for them. This slide lists some of the key organizations and sample tools related to the development and communication of value propositions. The table at the bottom with the colorful dots reminds us that there are guideline entities such as ASCO and NCCN, the National Community Cancer Network, that take patient affordability into consideration as well when they're making their recommendations. So primarily clinical, but also can have some now patient affordability aspects as well. And I'm sorry to sound like a broken record, but manufacturers cannot start too early on this, right? And given their increasing demand for value-based care, manufacturers need to adequately fund this core component. Now let's turn our attention to reimbursement. Reimbursement, and specifically reimbursement for physician-administered drugs is what I'm talking about here. This slide depicts the equation, if you will, of coding plus coverage equals, or should equal, payment. As everyone would expect, there are standardized ICD-10 codes for diagnosis, CPT or current procedural terminology codes for the provider services, such as an infusion or an office visit. And there can be different coding systems depending on the site of care, such as we have APCs, ambulatory payment classification codes for outpatient care. And then we have these things called DRGs, diagnostic related groups for inpatient care. But rather than go into further detail or go, quite frankly, further down that rabbit hole of coding, let's move to the next piece of the equation, and that's coverage. Coverage can be perplexing, as there's very little standardization, and often only exist in payers' black boxes. Some payers utilize their own treatment guidelines, and those are the ones that can be in the black boxes. Others will work with their provider partner institutions that have developed their own guidelines, and others just use externally developed guidelines. Oncology is a good example, or somewhat unique, in that everyone looks to the National Comprehensive Cancer Network, or NCCN's guidelines, with some payers even mandating coverage depending on the level of evidence categorization within the NCCN guidelines. Educating payers and guideline committees does not happen overnight. Emerging biopharma would be well served by starting to develop these relationships and initiating disease state and current treatment statement landscape educational efforts at least 18 months in advance of an anticipated product launch. The last element in this calculation is payment. As you would expect, payment varies by site of care, level of provider, payers, and other factors. We've discussed some aspects of payment related to the drug, but manufacturers must also consider payments related to administration of certain therapies. For example, if providers do not feel there's adequate payment for the work or the resources involved with administering a particular drug, they're less likely to prescribe it. It could be the case that there's no existing code to properly reflect a drug's specific aspects of administration. Examples have included coding and thus payment related to drug infusions, monitoring patients post-administration of the therapeutic. If it's the case that there are no existing codes that adequately reflect the administration of a therapy, the manufacturer will likely need to drive efforts to establish a new code. And getting a new procedure code can take years and will not only involve the American Medical Association, but also other provider associations representing the most relevant specialties and/or sites of care. Now, although there are a number of components related to reimbursement, a well thought out reimbursement landscape assessment or reimbursement roadmap can provide emerging biopharma manufacturer clarity of what needs to be accomplished and when to minimize reimbursement related barriers to access. And particularly if there are any nuances to the administration of a drug, an initial assessment should be completed a minimum of 18 months in advance of an anticipated launch in case that new procedural code is needed. So I know you all are fascinated by all this talk of reimbursement and the reimbursement equation, but we need to move on. So next up is distribution. This graphic fairly depicts the typical distribution model for an oral oncolytic. The product goes from the manufacturer to the 3PL, or what we call third-party logistics manager, that essentially acts as the manufacturer's warehouse. From there, the product goes to either directly to specialty pharmacies, what we refer to as I refer to as SPPs, or product is shipped to specialty distributors or SDs. And those SDs, those specialty distributors, supply physician practices, hospitals, and the Department of Defense and Veteran Affairs administrations. So those types of sites of care. Now, given the experience of the stakeholders involved in implementing a model, quite frankly, I feel like it's fairly straightforward. If you've done your homework and are aligned on the key aspects, such as where will the majority of your product be dispensed and the size of the anticipated population, because that will influence how big your network of net dispensing partners needs to be. Now, on the flip side, the more dispensing partners you have, the harder it's going to be to manage from a customer service perspective, as well as the cost and complexity of capturing data. Lastly, I'll mention the 340B program, because this program continues to be a hot button issue. Hold on a second. Yeah, I want to touch on it here. I don't know if y'all have heard of this program, the 340B program. I think it's come up, multiple times before. But the reason why I'm bringing it up in this context is because, in theory, a manufacturer could limit distribution to certain facilities. That's been tried in the past. I'm not a legal expert. I'm not a lawyer. So this is by no means advice. But the point is, some manufacturers have tried to limit distribution to certain facilities because those are, as I previously mentioned, those facilities automatically get a about an average of 30% discount right out of the gate for their product. So I just bring that up in the context of this because this could be a place where you could have some control over that distribution. All right, so let's move on to patient provider support programs. These types of programs and resources have become increasingly important to the launch and life cycle success of virtually all specialty products. In part, this is due to the constantly shifting benefit designs of insurance plans, including Medicare Part D, related to patient out-of-pocket cost. I'm talking about changes to deductibles, copays, and coinsurance requirements, as well as payer tools such as copay accumulators and maximizers, as well as delays in formal coverage decisions and coverage policies with very, very specific requirements. Manufacturers and their patient support provider vendors are really getting smarter about adjusting the financial assistance programs in response to plan benefit changes. But ultimately, the tactics used by payers are further diminishing gross to net for these manufacturers on these products. Note, emerging biopharma will typically outsource the administration of patient assistance programs and resources to one of a number of very competent vendor partners. Now, on the provider side, support typically involves education and support related to coding and coverage, and making them aware of the resources that are available to their patients. Depending on the product, manufacturers will likely also deploy field-based teams, typically called field reimbursement managers, or similar personnel, which I'll expand a little bit on later. My take on early key considerations for emerging biopharma would focus on one, assessing the potential impact of these financial assistance programs. In other words, the free money they're giving out to patients, sort of, because of the increasing and significant impact on gross to net. And two, quite frankly, just educating senior leadership to make sure there are adequate resources in the launch budget to support these types of services and resources. Okay, so just two more core components. First, access analytics or data analytics. As I've alluded to, there can be a myriad of sources from which data regarding operational efficiencies, volumes, drugs, and patient journeys can be aggregated. This graphic tries to depict the various data sources, including the hospitals, the specialty pharmacies, potentially physician practices, the 3PL, the specialty distributor, patient provider support programs, payer coverage platforms, as well as potentially EHRs, group purchasing organizations. And of course, if the manufacturer has a CRM, you'd want to plug that in as well. Now, all this data needs to be mapped and aggregated at the market access level, and then, or simultaneously, mapped and integrated with data from the sales and marketing to gain a complete picture. As this component doesn't require resources really until closer to launch, I won't go into further detail except to say that, in my opinion, market access needs to own this, meaning they need to own the strategy related to all data capture market access data and be prepared to present that to and partner with the manufacturer's internal data experts. So one more component to cover. This is an easy one, and that's field support. By field support, I mean the payer account directors, what we call payer account directors, field reimbursement managers, and potential patient support managers who are key to doing all the pull-through work related to contracting initiatives, educating and supporting healthcare providers and patients. There are a few key considerations, really, but ultimately this component, I think, quickly comes down to just execution. So I'll just mention some of the key considerations, including the number and type of prescribing providers, the number and type of sites of care, and emphasize the need to align with sales and medical affairs when planning out your overall field support team. And with that, I've covered a good bit today. Hopefully I've given you a better sense of at least the core components related to US market access from the perspective of an emerging biopharma, including certain aspects of market access well before a product launch can reap significant benefits for emerging biopharma. If I'm asked, what are the 2 or 3 most critical priorities related to early planning? I would say 1, start working on your value prop as early as possible. Phase 2, and potentially even during phase 1, for the value prop. And 2, my second thing I would say would really be get a full market access landscape assessment, or at a minimum, get a pricing assessment. And if it's a physician-administered drug, get a coding assessment done at least 24 months before the anticipated launch. Again, understanding cash is like oxygen to pre-commercial emerging biopharma. This work can be completed efficiently by folks like me working on a fractional basis. And with that, I'll say thank you for joining. And I believe we have some time for Q&A, so I'll turn the mic back over to Nigel.
Well, thank you, Doug, for, again, a fascinating walk through the landscape market access in the US. I guess what jumped out for me also, again, was, learning probably 2 decades ago now, a valuable lesson that we should be developing, not for regulatory approval, but for market access. And I think this chimes very loudly here again, the importance of thinking about market access up front very early on is key. That certainly comes out for me in the discussion. So thank you, Doug. But let's take some questions from the group. So I see Orna with your hand up. So Orna, can we start with you?
Thanks. So thank you, Doug. Really great presentation. I come from the medical affairs side, and I've been on the, I've been asked to input into the value proposition as early as phase 2, and it's always it's extremely difficult because you don't know your product that well at phase 2, right? That's why you're doing phase 3. Well, it's obviously it's a requirement, but it's a requirement in order to learn more about the drug and efficacy, safety, and that is the value proposition at the end of the day, right? How well is it balanced? How does it compare to other drugs available on the market? Those are not things that you typically are aware of, unless it's oncology or very specific sort of areas. You're typically not able to provide that. And I remember the folks from market access coming to me and saying, okay, so how soon can you give me a study that will tell me all these things? And I'd say, well, 18 to 24 months, come back, that's kind of, so I know I'm exaggerating a bit, but what would you suggest so how would you address this issue that the value comes later, but you actually need it very early?
Yeah, it's interesting. Yeah, the way you said that, there's kind of almost like the clinical value proposition, right? And then there's the financial, right? That type of value proposition, which a payer is typically looking for both, right? Ultimately, and what you're saying, and it makes complete sense, is it's really hard until you've got through the clinical and have enough data there to start going on. What I've seen, and I think typically in that earlier stage, you may have some of the data already, I would contend, and it's just things like, I know patient-reported outcomes, they may seem soft to some people, but when we're talking with these payers early, right, to your point, this is real early. So yeah, you'll be able to get a lot more data if you have a full phase 3 study, right? And that's where you can really, really beef it up. But I think from a market access perspective, what we're looking for is some essentially talking points for the pre-commercial conversations, right? The pre-approval conversations that we have with payers. If you think about it, and you've probably been in some of these discussions, right? These payer personnel, they cannot know in detail all the disease states, all the treatment regimens, yet people like you who are literally focused on your product's disease states, the treatment landscapes related to them, and all the details, that's where you have the opportunity to educate them. So when we say from a market access or financial value prop perspective, we're really saying, give us some nuggets, give us some talking points, try to plan early for those, so we're not, I don't know who you've worked with in the past, but I know I'm not asking for big things early on. I'm looking for a few little things, and quite frankly, what I've seen typically the easiest, if you will, is to just grab a couple of things that could be considered patient reported, quality of life type things. That I get it, they're soft, they're not going to play a role at the very end in the hardcore marketing, but they are going to help us get through those first couple conversations. Hopefully that helps.
Yeah, good point. Thank you.
Thanks, Orna. I'm actually going to come to Paul Reynolds. Paul, I see you've got a number of comments in the chat, so maybe you take us through those. But also, I see you highlight we actually have an example of infraction.
Well,
very much of what Doug's been talking about in the last few minutes.
Doug, your slides are magic because we are just doing this for a US pharma that's considering at 2A going to phase 3 and asking about everything you've outlined. So we've just done a round of payer interviews looking at TPP, asking them exactly the question you said. What particular data do you want to see in phase 3 to enhance the value proposition? And they've told us elements of quality of life data. They've told us about long-term extension data. They've said, build these pieces in because it's going to help you explain to us enduring value. So you're absolutely 100% on the ball on this. So first of all, thank you, because it's also reassuring me, Doug, that we're doing the right job when we're talking to this particular client. On the other questions, one thing that we've encountered is a biotech going to BioPharma comes in for distribution deals, looks at the myriad of wholesaler, specialty pharmacy, whatever, and then they start to realize that big pharma's already struck some very lucrative rebate deals. How does a smaller player come in, or how does a smaller player come in and navigate? For example, wholesaler percentages can be very heavy. how can you get around that if you've got no volume? Because you think if you're one of the big players, you've got a lot of volume to trade. When you've got a single product, how does that work for a biopharma? First drug in the market.
It's interesting you asked that. I actually have worked within, what do they call it now? Cencora. They call it Cencora. So it's AmerisourceBergen, which I think most of you are familiar with. It's one of the big three, right? The big three distributors. And I've worked closely with my partners over there from time to time. They want the business.
Right.
Okay. So even if it's a small product, small patient population, they still each want it. Right. And so then it typically becomes, okay, well, we're not going to use all three of you.
Right.
We're going to use two of you. We're going to use one of you. And by the way, if you get pushback, because typically I think it's McKesson currently that holds the official contract to distribute to the government, so the DoD, the Department of Defense, and the VA, there are ways around that. So if they say there's only, this is the only way you're going to access some of our, if you will, wholly owned or exclusive contracts, in my opinion, that's a little bit of smokescreen going out there. So I think really number one, they are interested in your business,
Right.
even if it's small. And number two, then what you do is you start saying, okay, obviously we don't have enough volume that it makes sense to work with all three of you.
Yeah.
And as soon as you say that, then they're like, oh, wait a second. McKesson doesn't want to be left out because they want their U.S. oncology practices. They want their U.S. oncology practices to be able to get the drug through their channel. AmerisourceBergen or Cencora doesn't want to be left out because they want their, and this is an oncology example, they want their ION, International Oncology Network practices to be able to get product through their, their internal channel. So they want the business, and it's just a matter of figuring out which one wants it the most.
Okay, and then one follow-on question: when you're looking at the support services you put in, like hub, patient access, and PAPS, what I'm learning is that if there's any friction between you and a competitor, you can lose out at the prescribing advisor, the back office person who's basically filling the papers out, if you don't have a service that at least competes with your competitor. So do you have to study closely what services are your competitors are offering and match it so that there's no friction?
Absolutely. Again, I referred to something else as table stakes. Oh, I was referring to the 340B discounts. To me, this is the same thing. Being able to do at a minimum what your competitors are doing is table stakes to even get at the game. When I first started my career in healthcare, I was on the provider side of healthcare. So I ran physician practices. I did consulting work with hospitals, health systems. And those, as you refer to them, back office people, they can effectively be gatekeepers.
Yes.
to a therapy. And if those resources aren't in place and they aren't comfortable with those resources, that's why I said in my comments that those things largely come down to execution.
Yeah.
Execute on those, you will feel the effects of it. And increasingly so over time, right? As all the payers have gotten more challenging to deal with, the out-of-pocket costs have become more. And let's be clear, no prescriber, whether it's a physician practice or specialty pharmacy or hospital system, is ever going to be happy with the amount of work they have to do to get a product approved by a payer and to help direct the patient so they can get the copay assistance, type resources. They're never going to be happy with that. But as much as they complain, they know it's just part of the system, and they'll work through it. But you have to come to the table, yes, at least with what the competitors have.
Thank you, Doug. Very good. Thank you.
That's also what I meant by resourcing appropriately.
Yeah.
I'm not leaving.
Don't leave, Doug, please. Because I think we have at least one more question from Phil. I don't know, Phil, if you want to come online, or I can read in the chat to Doug. So just Phil's asking sort of what level of access do pharma and providers have for prescribing? Do they have local, state, and national level data? So when looking at prescribing patterns,
What level of
how
access
far
do
can you drill
pharma
down?
and providers have? Well, pharma definitely has, pharma can get any, pretty much any level of data. You can essentially get data pretty much down to the prescriber level. It obviously has to be, can't be the actual, can't say Paul Reynolds, Dr. Paul Reynolds.
Yeah.
But it, you can put it together and you can figure out, oh, that's Dr. Reynolds. They have to keep, it's less from a pharma perspective about what level of data you can get. It's more about how much money do you have to get down to that level of data, right?
Yeah.
Everybody out there selling data.
Is
Phil?
IQ, sorry, Doug, and thank you very much for a really interesting presentation. Does IQ have a footprint in data?
Oh, absolutely.
Yeah, in America. Okay. Because in the UK, pharma has access to IQVIA data, but it's in a brick status where they aggregate selected hospitals into a brick, so you're not supposedly be able to even identify the hospital. So there's a lot of confidentiality in it, whereas for the providers, so the hospitals, they have access to what's called PharmX and defined data, which is patient level prescribing data. And I was just curious to ask the question.
Phil, we've just bought IQVIA data for a client, actually. One of the fraction partners acquired it. It comes back to Doug's point, is aggregation's the key in America, is that the data doesn't exist 100% in one place. It's all over the place because everybody sells their data. And although we bought a very, very good IQVIA data set, it's still only covered about 45% of lives. So even then we didn't get a full picture.
Right. Okay. Thanks, Paul. Thank you very much, both.
Yeah. Thanks, Phil. Good to see you.
Thanks for joining.
Okay. I don't know if I see any other hands up, actually. So just final opportunity to ask Doug any questions now. But I know Doug is...
Okay. Yeah. Doug,
Sorry,
this is an interesting question. Presentation. So quick question. I work in the US market. I worked at GSK before for several years. Question on reimportation. Like in the US now, certain states are allowing reimportation, like Florida or from Canada. You think that trend will continue over time?
I'm not the FDA expert in that area. I personally can't see how it can. I don't. I mean, that's just crazy to think drugs gonna leave the country or come in. Manufacturer. I mean, you worked at GSK. You said, right? Why would why would GSK, number one, necessarily ship more product than, for example, Canada needs? And number two, why would Canada let that product necessarily leave the country? Because then they wouldn't have enough product. It just on that. I mean, that's just my own really personal, non-regulatory perspective on it. Especially now. Think about it, Sanjay. They, with Medicare coming in with some of their new direct contracting efforts and so forth, I think there's other ways they're saying, look, we're going to address this issue, right? They got all the patient affordability. They're allowing, manufacturers, at this point in time are, upwards to 30-50%, is going off essentially gross to net, it can be like 50% because of all the patient assistance that's being provided. Add on top of that, these direct negotiations. I think it's a regulatory issue. I don't know. I mean, what's your take on it? Do you think it's going to keep growing?
Well, only thing is that there is this disparity in pricing, and you always compare price to ex-US, and obviously patients and the Medicare patients actually are going to say that, I'm not getting income, and why should I pay like, $10,000 more than someone else in UK is paying for the drug. So I think that debate will continue. Obviously, US is the fertile market, and that's where most manufacturers coming and charging. And what they're saying is value for the money. And so obviously that value proposition comes in when the high prices are actually compared with the other countries. But it's a debate. I don't know. We can solve. I don't have, that detail. But probably you are in the same area. I thought that you would probably have some insights into how that's shaping up.
I think Doug makes a great point. No, none of the big farmers are going to want to do parallel importation strategies between the US and adjoining countries. You've already got a little bit of cross trade between Canada and Mexico. We know a lot of Americans go to Tijuana to go and get their prescriptions filled. We know there's a bit of a postal service between Canada and the US. The FDA is quite lax on individual importation of drugs for a limited supply. So if you are persistent, I know in IPF you could buy Ringer or Genentech's product from India through Canada for a fraction of the cost. But again, as long as you only imported a month's supply, it was okay. If you started importing a truckload, then you go to prison. So I think the control, as Doug says, the legislation is changing, the government acts are changing, the patients are slowly paying less. Inflationary increases in drug prices in the US are likely to dampen us a little bit as well. So maybe this five-fold difference between EU and Europe and the US is going to slowly dissipate, but I don't think anytime soon.
Well, Paul, my comment about the gross to net, that I want to mention that how'd you refer to it between, for example, EU countries. When I used to work on the physician practice side, we had gross charges, right? And my physician partners, they would just go crazy over, why are we charging this much? This is way too much. And I would tell them, gross means nothing. We don't get paid gross.
Correct.
We get paid gross on 0.01% of our services. I think that needs to be, that should be a message from pharma, right, to the government and other entities. Manufacturers are not getting the prices that we hear, right? I think the average for new drugs now is around 50% of what you may see as that quote unquote list price or gross price.
To give you an example, Doug, when I was working at GSK Sanjay, I worked on Avamis and Veramis. Now, Veramis was in the US, charged at $100 a month. And in Europe, it was about £15. When I spoke to the US president, which at the time was Deirdre Connolly, I remember, it was a long time ago, Deirdre said that the actual net was about $25. That's what they actually got for that particular type of product, because it was obviously a limited differentiation and, a big deal, volume deals. So Doug's right. Sometimes the legend of five-fold prices, actually the reality with gross to net is that it's probably 2.5 times maybe.
Right. Yep. All right, Nigel, what else? Anything else?
Well, I'm just checking with the group. I don't see any hands up again, so just conscious of time. So we'll end now, I think. But thank you, Doug, for a fascinating discussion. I'm sure you're freely available to anybody within the network and beyond, of course, for any follow-up discussions. I know perhaps Gordon had some questions in another slightly related area as follow-up as well. But again, shameless sell if you like, but again, what pops out of the page for me once again is, these are tremendously important and complicated areas. And even young startup biotech type companies need to be thinking about these things very early on in their life cycle, and they need the expertise to do that. And whether that's a particular function or cross-functionally, the brains within the organization, the group here, can provide that to those types of companies. And we have a very strong, powerful offer within the fractions community. And Doug, you're an exemplar again of that today and the discussion that followed it. So with that, come back next week. You'll soon get new details of Anya, who's going to look at market access closer to this side of the pond in Germany next week. So look forward to seeing you next week as well. So with that, wish you a good day and thank you again, Doug.